Okay. Hi, and welcome to the second episode of our Dermlite on the Spot Dermoscopy series. We hope to provide you some tips and tricks you can apply immediately on the spot at the point of care while you're looking through your Dermlite. In case you don't already know me, my name is Torsten Trotzenberg, co-founder and head of design at 3Jet. I've been responsible for the design of every Dermlite ever made, starting with our first product, the world's first polarized dermatoscope. And it's actually our patented polarization technology that gives you that clean, deep view into the tissue with your Dermlite. So in today's installment of the On the Spot series, titled Algorithms, How the Experts Use Them, our goal is to keep laying the groundwork for future episodes. And I'm absolutely delighted to have Dr. Raimund Karls with us, a highly experienced dermoscopist. He's the reigning world champion of dermoscopy, and he's a good friend. For those of you who don't know Raimund, he's based in Latvia's capital, Riga, a beautiful city. A few years ago, over some drinks in Tbilisi, which is in the Republic of Georgia, Raimund and I decided to do what we could to expand dermoscopy knowledge in the former Soviet republics. And it's been an exciting adventure, and it's great to have so many doctors from there watching us right now. Hello and welcome, Raimund.
Yes, hello, Torsten. Nice to be together with you and together with all the world. So I think that show must go on.
Thank you. It must go on. So I'm so thankful to you and actually all those who've been supporting our efforts to expand dermoscopy knowledge worldwide.
As we talked previously, we are spreading the infection of dermoscopy.
Yeah, yes, it's.
We're going to positively infect people.
Can we say it's a pandemic?
You know, I think that nowadays it's really pandemic.
But yeah, it's amazing the way our products and ideas have really revolutionized the way most of you do dermoscopy today. And like I mentioned 2 weeks ago in our first episode, I feel like when we support training in dermoscopy and equip you with a Dermlite, we sort of feel like we've given you superpowers. And as you know, you can do a lot with superpowers. We have some huge problems in today's world. You know, we're in a crisis mode, much of the world is. So maybe you could even create this amazing algorithm that solves some of the world's most pressing problems. So if you could design this algorithm, what would that algorithm solve? And we have the magical powers of Zoom, and there's a polling feature. And I'm going to ask you, what problems would you like to solve? And you can vote now. And it's multiple choice. You can pick as many as you'd like. This is basically showing you how polls work in Zoom if you haven't used it. Give you a few more seconds to vote. It's interesting.
Annoying neighbors will be the leaders.
Yeah, that's a good choice, Raimund. I hope your neighbors aren't watching.
I'm living outside the big city. I'm happy for my neighbors.
All right, let's wrap this up. What's your money? Where's your money on what answer is going to win out, Raimund?
So, Dr. Google.
Let's. Well, all right. Okay, thanks for your responses. That was fun. So now you know now that you know how the polls work, you'll have the chance to answer some or take some polls later on and answer some questions about more relevant subject matters. And another feature here available on Zoom during this episode is that the Q&A icon. You can ask questions at any time by text, and you can. I will see them and I will pose them to Raimund after his talk. So that's how we're going to do it this time. Anyway, we're ready to begin. Raimund, the stage is yours.
Okay. Thank you. So we will go with this slide. My slide is visible, just for check the situation. Torsten?
Not yet.
Yeah. So, of course, if we start to talk about the algorithms. Oops.
Share your screen.
Share my screen. Okay. And oops. And oops.
There we go.
Yeah, here we are. So, of course, first of all, vivat to all participants. I see that this algorithm brings the peoples and doctors from all over the world. And as far as I know, the top 10 countries are Brazil. Welcome, Brazil. Welcome, Egypt. Welcome, Philippines. Welcome, Russia, Ukraine, Azerbaijan, Kazakhstan, United States, and of course, I cannot forget about my neighbors like Estonians and Lithuanians, and we will start. So, my name is Raimons Karols, really from Riga, Latvia, and just for those who want to know where is Latvia, and I would like to show just a few slides about my country. As you see here, we are a small country on the bank of Baltic Sea. On the right side, you see the capital of my country, it's Riga, and our climate is very, very good because we have really 4 seasons. We have winter, spring, summer, and also autumn. During all these seasons, country is very beautiful. You see ancient, you see modern buildings, you see medieval buildings, and of course, we are living on the bank of Baltic Sea, and on the left side up, you see the point where the Baltic Sea meet Gulf of Riga. Our peoples like to sing, dance, and also spend some time on the beach. And we are very proud also for our ice hockey team because we are a small country and we are really proud for this. And as already Torsten announced, we are also proud for the fact that Latvia is the second team after the team of Poland who wins the World Cup of Dermoscopy 2 years ago, really in the same days, just June 2018 in Thessaloniki. We're in the final battle. I will say we meet the teams from Serbia, Thailand, and United Kingdom. And the world champions now lives in Riga, in Latvia. And I'm also very proud that all the team is from my clinic. And here you can see my ladies, my doctors. From the left, Elina, Agnes, Alice Ilse, and Dr. Karls. So, yes, at this moment, the cup is located at the reception of our clinic, but I think that today the talk is not about the World Cup, but maybe once upon a time, I also will write the algorithm about how to become a world champion of dermoscopy. So if we are going to the small details, of course, by the definition, what is the algorithm? It's a set of rules that precisely defines a sequence of operations. And on the left corner up, you see the small sign, and this sign will appear separate many times today, and it means that we ask you to be ready for voting. And the first question from me is, please show, Torsten. So, the first question is very easy. How many dermoscopy algorithms do you know? 1 or 2, 3 or 5, 6 to 9, 10 or more, and very democratic, I don't know any. So, Torsten, which will be the winner? How do you think?
5 to 10, maybe.
5 to 10. Okay. So, can we see the results? results are okay. 32 majority. If we will put together 32% and 32%, it means that it's a really majority. So, well, that's good. I think that this is a very good choice to talk today about algorithms. Why? Because you will see that algorithms are really much more than we expect. So the second question is,
It's coming.
It's coming. Yes, which is your favorite algorithm? So you can choose multiple answers, not only one, because different algorithms are for different purposes. That could be interesting. I think that the most favorite could be the oldest one, ABCD, but due to metaphoric language and Harald's language, one more also will be very famous.
We forgot to put the Dr. Google algorithm.
Yeah, Dr. Google, yes.
Well, let's share this.
Okay. Pattern analyze. Good. Okay. It means that majority, 1/3 part of participants are using pattern analyze. Good. We will talk about patterns today a lot. So, and the third question.
Yes, it's coming.
And the third question is, how many algorithms do you use daily? Or maybe not so only daily, but in your practice, you are not using more than 6. Good, we are ready?
Okay.
Well, 2 algorithms, almost half of participants are using. Yeah, good. Okay, I hope that after this talk today, you will use much more algorithms. So let's take a look. What in reality do we have with the algorithms? There you can see a timeline. And at this moment, we can talk about more than 25 different algorithms which could be used in dermoscopy, which could be used for different purposes. It could be used for differentiation of melanocytic versus non-melanocytic, melanoma versus nevus, inflammatory diseases, etc. And we will talk about this right now. And one more next question. So just check what is this lesion. So please vote. So I can imagine how fast is this signal from Brazil to Zoom, from Zoom to my computer and to all the computers. It means that we need to have a small time to receive all the votings. So
3 more seconds. 3,
2, 2, still 2, 0, half a second, and the answer. Well, melanoma on trunk, excellent, 71%, good, super, super, it's really so. So, of course, majority of you said that you use exactly the first known kind of algorithm. It's a pattern analyze. In reality, it was really published in 1987, and it was like a first algorithm. Of course, it was not so easy to use, especially if you are not expert, if you are a beginner, and for many of doctors who start to learn dermoscopy, of course, this was like a nightmare because every feature, every criteria have their own histological correlation. And of course, every criteria can belong to benign and also to malignant. So, and at the same time, this pattern analyze we are using still nowadays, and here we can see the different patterns of vascular lesions like angiokeratoma, angioma. Here we can see a different patterns of melanocytic lesions, dots, globules, streaks, etc. Here we can see a different criteria and also patterns of the melanoma, and melanoma not only on the trunk but also on the locations, not only pigmented but also hyperpigmented melanomas. But of course, if we are beginners of our way on dermoscopy and we are beginners of our way to World Cup of dermoscopy, we are starting to learn dermoscopy with something very, very easy. And this very, very easy is a two-step algorithm. So the beginning of any lesson on dermoscopy starts with the first step. First step is differentiation of the melanocytic versus non-melanocytic lesion. And of course, if we are decide that this is a melanocytic lesions, we need to differentiate. Is this benign and this is a nevus? This is a melanoma and there is no doubt melanoma, then cut it out. Or maybe the patient is coming with 1,000 different lesions and we need to think, what is this? This is suspicious. How suspicious it is? It's suspicious for the excision or it's suspicious for follow-up. And of course, another one step, if we are going and finding that these patterns are belonging to non-melanocytic lesions, like dermatofibroma, etc., we are not applying those algorithms which belongs to the group of differential diagnosis of melanoma. So, of course, different small letters are written on every lesion. These letters we are calling like a criteria. When we put together different criteria, we get the word. And this word we later put into the sentences. And in this way, this is my approach, we are reading these signs, we are reading these letters of the lesions on the skin of our patients. So, of course, what is the most important? We are talking about the melanocytic features, melanocytic criteria. One more time, dots and globules, network, streaks, homogeneous or structureless areas. And for some special areas like acral skin, we are talking about the parallel pattern. Another one pattern is all these features and criteria which shows that this lesion belongs to seborrheic keratosis. Milia-like cysts, comeda-like openings, of course. At the same time, it depends which of the languages we are using, metaphoric or we are using Harold's criteria, this language. But the beginning of the dermoscopy was with a metaphoric language. So one more time, there is a criteria for vascular lesions like lacunas, like keratosis on the surface, and etc. So the criteria for dermatofibroma and of course typical dermatofibroma, which we see here, and not so typical dermatofibromas on the other pictures. So, and then we are going to some special things like an accessory nipple, which also looks like dermatofibroma, but it's not so easy to recognize if we don't know nothing about the clinic of this lesion. And when I show you that this belongs to the young lady or maybe also a young gentleman, and this lesion is located on the front, we can say that this is an accessory nipple. So then criteria for basal cell carcinoma and the most beautiful vascular patterns like arborizing vessels is really typical for basal cell carcinoma. Then next criteria for actinic keratosis, and we we can say that red pseudo network, we can talk about the strawberry pattern, and we can talk about the confluent follicles and transformation of the actinic keratosis into squamous cell carcinoma. Special patterns which we saying that these lesions belong to the group of Bowen disease, glomerular vessels and scales on the surface. We see 6 different lesions. They look different, but all of them are Bowen disease. Next, keratocantoma, also the group of squamous cell carcinoma, but at the same time, also there is a lesion which have some vascular pattern and also have a keratin and a lot of keratin. So, and one of the last, this is a squamous cell carcinoma. Also, squamous cell carcinoma have different patterns, different criterias. Of course, there is a polymorph vessels, as we see here, different amount of keratin, starting from white keratin, as we see here, and yellow keratin. And with the dermoscopy nowadays, we are applying some algorithms, and we are saying that this is a low degree, or this is high degree squamous cell carcinoma. And last, this is lesions which have criteria which is very hard to recognize and very hard to put them into one basket and say with confident that this is a sub-K, this is basal cell carcinoma. And all these cases, the algorithm says that we must evaluate this lesion like melanoma, and melanoma must be kept in mind. So, of course, this two-step algorithm, as you see here, there is first published by Stolz in 2002. It was a little bit upgraded by Andreas Blum, and we hear Andreas Blum 2 weeks ago with a beautiful story about the light in dermoscopy with a polarized and non-polarized light. But what we are doing, we always remember that diagnosis of the given skin lesion must not be based on presence of on one single criteria, but we are evaluating and we are trying to recognize all the criteria which are visible on this spot. So, and for recognition of the spot, of course, we can use different algorithms. But first, I would like to remind you that this algorithm, like ABCD, we can use very successfully only in case if we will really find the criteria for melanocytic lesion. Otherwise, all good dermatoscopes in our hand, all our knowledges will go in a wrong way. So just to remind you that ABCD was the first algorithm which was introduced, and this was an algorithm which gives us possibility to count, to give an objective of points. Here you can see that this counting is not so easy, but it works very precisely, and the idea is very easy. Take a look to this lesion. Yes, there is no problem. We recognize these dots, globules. We recognize blue with the swale. We recognize irregular network. We recognize structureless areas. And of course, we are talking about the melanoma. Another one lesion which looks maybe much more neglected, but at the same time we see, of course, these sharp demarcations, and from the very first sight it looks like much more ugly than previous one. But if we will take a look that this is a seborrheic keratosis and don't apply ABCD rule to sub-Ks, even if these sub-Ks look so ugly as this one. So immediately after ABCD, there was some possibility, some authors who tried to modify ABC point list of dermoscopy. And here you can see some modifications, but I would like to say that still this moment we can find this in literature, but maybe not so often used. But at the same time, we can say that all these algorithms are really very good because they help, especially for the beginners. And here you can see that the amount of points, and there is a threshold. If we have an amount of points less than 4, we can say with a very big possibility that this is benign melanocytic lesion. And at the moment when this sum of points are more than 4, we are talking about the high possibility of melanoma. So, of course, counting so many criteria, multiplying is a little bit problematic. And next step, which was introduced by Australian group, it was led by Scott Menzies. It was introduced that we can find positive and negative features. It means that negative feature must not be presented. If we have a symmetrical lesion by pattern, or we have the presence of single color, we are saying that this possibility, this chance to be for this lesion to be a melanoma is very, very low. At the same time, if we have these positive features and one or more, and take a look, there is a list of these lesions. And of course, in nowadays, we are a little bit smiling because there are pseudopods and radial streaming, and nowadays we are putting them in general, we are putting them together in one feature. So there is an example. We have a lesion with a homogeneous color, one color, nothing more, and we see this lesion with a regular or typical network, and we can say that this is features for benign lesions. So at the same time, we see lesion with a maybe a little bit different network, but it will be also very interesting if we will give you a chance for voting. But I will say that in nowadays we are saying that when we start to see these features like angulated lines here, we are talking about the melanoma on sun exposed skin. It also comes from Australia, but many, many years later. So, of course, next, if we are talking about the 7-point checklist, the same as we are saying, who don't know Geppi Argenziano? Everybody knows Geppi. And so when we take a look, this was also the end of last century when the Geppi introduced. So he said, I don't like to count so many points. Better let's do in a way. Let's take major criteria, let's take small criteria or minor criteria, and if we have 3 or more points for major criteria, there is a 2 points. For minor criteria, 1 point. If we have 3 or more points, this is a very high possibility that this will be a melanoma. And for all others, we can see. So, but a little bit later, it was a, you see, 7-point checklist, and Geppi goes back to this algorithm and said, okay, at the end of last century, I said this, but now we can a little bit upgrade this algorithm, and for every feature which is presented on the current lesion, we are giving 1 point. 1 point for irregular streaks, 1 point for irregular blotches, for regression structures. And it means that at this moment, if we have at least one feature, we are thinking that this lesion is a melanoma. No more discussions. Really no more. Why? Because it looks that it will be melanoma with a very high possibility. So, and we just take a look for this lesion. We see this atypical vascular pattern. We see irregular network here, or atypical network. We see irregular streaks at periphery. At this moment, in nowadays, it's absolutely enough criteria to be a high suspicious lesion for melanoma. So, but also Geppi's algorithm also undergoes some modification, and there is a publication from 1999, and authors introduced the idea to calculate also some points like regression erythema, radial streaming, gray-blue veil, what we know like a blue whitish veil in nowadays. So irregular pseudopods, so irregular streaks, etc., etc. So this is also one more approach to calculate these points and get that idea about the melanoma. So, but I will say that the growing amount of melanomas, a growing amount of skin tumors. Of course, it caused the interest not only in dermatologists, but also for those who are like general practitioners or maybe like nurses for the screening. It means that we need to screen much more people to find the melanoma earlier. And in year 2004, there was introduced another one algorithm. This is a 3-point checklist of dermoscopy. There is a group led by Peter Sawyer. There is also JP, as you see, Iris, and a lot of other good colleagues. And the idea was to create an algorithm which use only 3 criteria, like asymmetry, like a typical pigment network, and blue-white structures independently. Are they really blue-white veil or only blue-white color? And the lesion is suspicious if the amount of points are 2 or more. So if there is only 0 or there is 1 point, this lesion is benign. And take a look to these examples. On the left, we see this lesion with the asymmetry of structures. We see a lesion with the presence of bluish color. There are 2 points. Another one example on the right, we see irregular or atypical network. We see bluish structures, and of course there is asymmetry. So 3 points, and this is a melanoma. And the third one, we see also asymmetry of the structures. We see bluish, blue-white structures, and there are 2 points. But in this case, this is a pigmented basal cell carcinoma. And one of the conclusions for this algorithm by this group was to introduce the algorithm not only for finding melanoma, but also find any other malignancy. And I will say that this is really very good algorithm when I teach my groups together with Torsten in Kazakhstan, in other countries. This is the most famous algorithms which doctors, especially beginners, like, because there is only 3 features. It's very easy, not necessary to have your calculator, not necessary to have your mobile phone to calculate these points. So, but there are 2 melanomas, and you see these 2 melanomas, this is really melanomas. Why they melanomas? Because we know that this is a parallel pattern, but this is not a nevus, and this is also melanoma. Of course, this is some asymmetry, but this melanoma is on face. And the idea is that majority of algorithms which was introduced for the differentiation of nevi and melanoma, they are not working on special locations like acral, like mucosa, and like a face. That's why there are some algorithms which was specially introduced, and this is a so-called BRAF checklist or BRAF algorithm. I put together checklists and also algorithms, and it was published not so long time ago, and by Emilio Slalas and group. And their idea is to put the criteria which can help us to find the acral melanoma. And B, RAAFF, you see these criteria, and the total score is 1 or more, and it means that this is a melanoma. It works really also very, very good. And one example from my colleagues from Kazakhstan with a slowly growing lesion on the finger, 62 or 63 years old lady, and we see this typical location of the pigment on this area. So next, of course, we will switch a little bit from pigmented lesions to non-pigmented lesions, because non-pigmented lesions are also very, very important. We see a huge amount, and there is also a great masquerade of these lesions. It could be benign, it could be inflammatory spots, it could be also a melanotic melanoma. And if we are talking about non-pigmented skin tumors, there are two beautiful publications, and all this could be put into one algorithm, which can help us to recognize and to differentiate non-pigmented lesions. How are we doing this differentiation? Non-pigmented lesions can belong to one of two groups. If, in majority of cases, if we have, with some exceptions, of course, some exceptions could be, if we have a solitary lesion, it more probability that it will be a tumor. It could be basal cell carcinoma, squamous cell carcinoma, etc. Of course, those experts who are also sitting in front of computer will say, well, it doesn't work in Gorlin-Gold syndrome, etc. Yes, right. But if we are talking about the rules, as a rule, that tumor is single. And if we are talking about the inflammatory lesions, they are multiple, or they can affect big areas. So, and returning back to this publication, first step in this algorithm is to define, is this lesion single or multiple? Next, morphology of vascular patterns. It means what kind of vessels we see under dermoscopy. Next, how they are arranged in this lesion. Then, if we detect, and I will show you in a minute this additional criteria. We are looking for additional criteria like hair growing, like scales, like remnants of pigment, etc. And then we are going to the final diagnosis. It means that if we are looking, and this is a melanocytic lesion, and we are recognize that this is a coma vessels, erythema, dots, milky red globules, and step by step we are going to the diagnosis. Please remember that almost every lesion with the polymorph vessels will lead us to malignancy, not only in melanocytic group, but also in non-melanocytic group. There are different kind of malignancies. Of course, in polymorph vessels in non-melanocytic group, it is more probability for squamous cell carcinoma, because if we are talking about the basal cell carcinoma, we see here, and there is a blood vessels branching or arborizing vessels, and this, of course, is a little bit another nature of this tumor. So, good, and of course, not to talk some words about the algorithm which was introduced by Cliff and Harold. It will be not a good idea, but I think, and we also talked with Torsten about the idea that who could talk better about the house and clues if not Cliff or Harold. I have only one slide about this. It means that this algorithm introduced to find some clues to chaos, some clues for the lesions, and then, of course, not to use metaphoric language, but give the names of the structures as they are. Lines are lines, dots are dots, clots are clots, and different kind of lines like thick, thin, reticular, branched, etc. But I think, of course, the best way to learn this is to hear from the authors. That's why I'm going one more time back. You already have seen this lesion, but now I have a question, because it's time also for you to say. Please take care. Please take a look carefully to this lesion, and there will be a question, and this lesion will be not visible during the when you will see when you will have a chance for voting. I hope that everybody looks carefully. And I think, Torsten, we can show the question. So the question, maybe I will say, the question will be about the thickness, because thickness of melanoma is very important. And I would like to introduce you to vote for the thickness of this melanoma. How thick could be this melanoma? Torsten, can we start? So is this melanoma in situ? Is this thin melanoma? Is this intermediate or thick melanoma? So the electrons are running in one direction and back. So 3, 2, 1, 0. Okay. And the results are, so intermediate, exactly. It means that you are really correct. So it means that when we see clinically suspicious lesion, we apply dermoscopy. We also can predict. Of course, we cannot replace morphological examination, but we can predict, and we also can predict not only the Breslow thickness. Yeah. Oh, yeah. Okay. We already have seen. And there are two interesting publications. There are two algorithms which dedicated to this idea. First one was published really very, very soon after the introducing of ABCD score. And here you can see that those melanomas who are thin melanomas and also these thick melanomas, they have different ABCD criteria. And ABCD also could be used for the differentiation. I will not going into the details, just take a look one more time. You can imagine for yourself what could be the approximate thickness of this melanoma, and I will show that this is a melanoma 0.3 millimeters. It's a very thin melanoma, and at the same time, two pictures of melanoma with a Breslow 2.1 and side-by-side comparison of melanoma of the same melanoma and polarized and non-polarized light. So, and another one algorithm also dedicated to the measuring of or predicting of thickness for melanoma is based on clinical palpability and evaluation of dermoscopic structures. It means that clinical, if we are talking about thin melanoma, it must be flat. If it is palpable, it could be intermediate. And if it is a nodular lesion, we are talking about the thick melanoma. And this group of authors introduced to evaluate pigment network, blue, whitish veil, and atypical vascular pattern. Here you can see, and this is really very interesting, that this algorithm also is very helpful for the predicting of melanoma thickness. So, of course, by blue whitish veil, what we understand like a white scarred pigmentation, blue pepper-like granules, and combination of both. So next step, there are equivocal melanocytic lesions, and of course, very easy algorithm, more regression, more asymmetry, more colors, more possibility for malignant. And one more lesion. I also introduce you, I invite you to vote. Take a look carefully.
This is the right.
So, is this a lesion lichen planus-like keratosis, dysplastic nevus, melanoma with regression, just dirt, solar lentigo, or hollow nevus? So, and the count 3, 2, 1, 0. And the answer is, well, melanoma with regression. Good. The second most popular answer is lichen planus-like keratosis. This is the first time today when the majority is wrong, because the correct answer is lichen planus-like keratosis. But I will give you another one chance. One more lesion. Take a look carefully. And I also invite you to vote for this. And the answers will be very similar. So, Torsten, please. So, is this also lichen planus-like keratosis, dysplastic nevus, melanoma with regression, dirt, Sutherland tiger, or hollow nevus? Zero. Okay. So, and the winner is, yes, absolutely correct. This is a really melanoma with regression, almost completely melanoma undergo regression. Okay, and the algorithm for these lesions is very easy. If we see these structures which are visible on the area that less than 10%, no excision. If it is 10 to 50% and more than 50%, of course, more regression, more possibility for melanoma. Okay, of course, in nowadays, not to say nothing about the one of the famous algorithms, I will say, in United States, like a triage algorithm by Ash Marhoub. It also will to say nothing, but I will think that there is also, it's really very interesting. It's very helpful. It's very helpful not only for the experts, but also for beginners. It's available free on publications, and I really recommend you, especially if you are a beginner in dermoscopy, to learn this algorithm. So then there are some algorithms which are not only dermoscopy, but which combine data from the clinical point of view, and this is especially like a Spitz and Reed nevi. Also recommendations by International Dermoscopy Society. Very interesting things. Next algorithm which I introduce and recommend to read and to know, this is so-called CASH algorithm, especially for those who are starting the dermoscopy way. This is a very good algorithm for the early differentiation of the dysplastic nevi, early melanoma, and nevi. Take a look. There is a little bit another approach for this. There is a color, there is architectural disorders, there is symmetry, there is homogeneity. Of course, it's a little bit tricky, especially for young doctors, to differentiate, is it mild or moderate or maybe marked. But anyway, idea is very, very simple, that we can count the points, and we see that melanocytic nevi have less points and melanoma have much more. Maximum is 18 points, but this is only by mathematics. So some more others interesting algorithms. This is an algorithm which is dedicated to the differentiation of early melanoma and atypical nevi, but this is not only dermoscopy, this is mostly put for risk scoring. And here we can see that we can calculate risk factors like age group by age group, different age groups, by different diameters, by different body areas, and also we can combine with the dermoscopy. Next, combination of dermoscopy and confocal microscopy. For those who are working with confocal microscopy, it's very, very helpful, especially in situ melanomas. And when we are talking about in situ melanomas, one of the most famous in situ melanoma is lentigo maligna, like in situ melanoma on the face. And the challenge for the face lesions, for the pigmented, flat pigmented lesions on the face, always is differentiate pigmented actinic keratosis from lentigo maligna. And there is also publication and these small algorithms since 2018, which could be helpful for this differentiation. And one of the last algorithms, which was also introduced by International Dermoscopy Society, which is dedicated for the general dermatology. It means that first publication about the general dermatology and use of dermoscopy in general dermatology, it was in 2004, many years ago. And now we have some recommendations how to manage these lesions. First, we need to evaluate the vascularity. It means what type of vascular structures do we see. Very similar to the algorithm of non-pigmented lesions. Next, how are they located? It means that arrangement of these vessels. You see dotted vessels in lichen simplex chronicus, in rosacea, in discoid lupus erythematodes. We see additional criteria like scales and color of the scales, like a white, yellow, or brown. Then we also can talk about the spreading of the scales, central, eccentric, peripheral, or patchy. Next, especially on the face, there are additional criteria like follicular changes, and there could be plaques, dots, pigmentation, white or brown. And all this together gives us really some kind of algorithm how to get the correct diagnosis. But if we are talking about the general dermatology, of course, if we take a dermatoscope without any clinical data, it will be nothing. We need to know something about the clinic. And of course, examination with a specific clues, which are very well known, like Wichemstria, like double rim of keratotic, double keratotic rim, or this air jet in case of scabies. This is a very well known and pathognomic findings. And when we find this, we can say, yes, we are right. So let's try apply this algorithm to this gentleman and take a look carefully. This is a clinical manifestation of this gentleman. He is 24, a little bit itchy lesions on the trunk. And this is a clinic. This is a dermoscopy. And I hope that Torsten will give us possibility, give us a chance for voting, what it could be. So, just a nevi, just a solar lentigo, just a seborrheic keratosis, multiple dermatofibromas, ink spot lentigo, or something other. So, 3, 2, 1, 0. A little bit, okay. Yeah. So, and the answer is junctional nevi. Bravo. It's not correct. Really, this dermoscopy looks like junctional nevi, but as I say, they are slightly itchy, but at the same time, I said nothing about the anamnesis, about the history of this lesion. This is a patient with a mastocytosis, and it's really very interesting that in this case, clinical information will be much more important than dermoscopy, because starting from this day, you will know that mastocytosis and the mastocytosis, these small spots, looks like really like a junctional nevi. So I think that it's really a time to finalize my talk, and I would like to finalize with some take-home messages how I'm applying my algorithms. First, my algorithm is to look to all lesions. This is not a new idea. We must examine as many lesions as we can. Very often patients are coming and saying, oh, doctor, please take a look to this spot. I don't like, I would like to remove it. Is it good or benign? And at this moment, when we're asking to get naked, we can find different things on the patient's skin. Undress, especially undress high-risk patients. It is very important, and it's important to look all lesions, and especially in the high-risk patients. I like to apply 3 to 10 seconds small algorithm. It means that if we recognize the pattern of the lesion, we doing it immediately. It's a very often mentioned idea. If we are saying elephant or we will saying cat, we imagine it immediately and we know how does it look. If I find something which looks different, which looks not so typically, I apply this algorithm and it works very good. Compare and monitor multiple moles and multiple lesions. Yes, it works very good, especially in high risk patients, and then apply pattern analyze and take a look what neighbors are doing. Are they doing something? Are they looks like each other, or they are different? This is very important. Never follow up nodular lesions. Never follow up nodular lesions if we are not sure that this is nevus, this is angioma, or this is sub-K. All other lesions, especially nodular lesions, must be excised, must be undergo biopsy. And of course, there is a very important to put together clinical, dermoscopical, and morphological criteria, because the best algorithm is your good feeling that all these things are coincidence which is each other. Otherwise, if we haven't this feeling, if the clinic doesn't correlate with the dermoscopy, or dermoscopy doesn't not correlate with the morphology, there is not good feeling and there is something wrong. So, of course, we can talk about the algorithms several days, but this is my overview of the algorithms. And I know that some participants also sent some cases. Dear Torsten, how we are doing? We are going to these cases, or we are starting session with questions and answers?
We have some questions from people.
Okay.
One of the most common question was the difference between LPLK and melanoma with regression.
Yes, this is a very tricky story. Why? Because in both cases we will see a lot of gray color, a lot of gray dots. Of course, if we are talking about the melanoma on the face, especially early melanoma on the face, which also could be represented with a gray color, this is the clue for the differentiation. If we are talking about the differentiation LPLK from melanoma with regression, so my approach is I like to use polarized and non-polarized light. Why? Because melanoma, and for melanoma, we will find these crystalline structures. And if we will go back to this case, which I show you with the LPLK and melanoma, those who take care, who looks very carefully, they see that this melanoma with regression have also these white lines, white crystalline lines. This is one of the possibility for differentiation. Otherwise, if you are in doubt, make a biopsy.
Okay, good. People are wondering, is there an algorithm for slowly growing melanomas?
For slowly growing melanoma, the algorithm is first, of course, make a TBP, total body photography. This is first, and sequencing digital dermoscopy, and follow this. In some patients, we need not wait until the melanoma criteria will appear. If we will see that lesion is have some changes, any changes, other lesions are stable, it is a good reason to make a biopsy for this lesion. And very often we can find that this lesion is a melanoma. Very thin, very early melanoma, but this is the approach which is also introduced by artificial intelligence, and also this not only dermoscopy, but total body dermoscopy. It means that with the newest technologies which comes to the market.
Okay, another question is pigmented lesions of the face. How to differentiate between a benign lentigo and a lentigo maligna?
Yes, that's also very good. First, I like to differentiate starting with the clinical manifestation. If we are talking about the lentigo maligna is usually, as a rule, it will be single lesion. If we are talking about solar lentigo, there will be multiple, because there is a sun damaged, but in the case of solar lentigo, there will be multiple lesions. And next, of course, I think this is a very good idea to have a separate spot about the flat pigmented lesions on the face, because there is not only a differentiation between lentigo, solar lentigo, and lentigo maligna, but there is also pigmented actinic keratosis, there is also seborrheic keratosis, and LPLK also could be added to the list of these differentiations.
Okay, next question. How do you reliably differentiate an irritated sep-K from a keratinizing tumor, SCC?
Yes, this is a very good question. Of course, if this tumor is malignant, we will see a little bit more polymorphism of the vessels. If I see that this is irritated sep-K, mostly we will see these hairpin vessels, these loop vessels, and we also will see this whitish halo around these vessels. But if I see this whitish area and in the central part I see something strange like these polymorph vessels, then I will be more preferable to think about the malignant tumor of keratinized tumor.
Then there's a question about skin of color. Any algorithms, or do these algorithms work well for those?
That's very good. Till this moment, I don't know any algorithm which will be published and which will be dedicated to this topic.
Let me see, there's more coming in. How do you use ink to ensure it's a parallel ridge? How do you do that?
Well, yes, it's a really very good idea. It's like a small trick. We are taking any marker. We apply this marker on this spot. Then then we clean with alcohol, and we are following, and we will see this distribution of this color. If these lines correlate with the pigmented sulci and giri, and it means these ridges and furrows, and in this way we are going to differentiate this. It's a very nice publication, ink test, and it's also available free on internet resources.
Okay, and then one question: what is your favorite algorithm?
My favorite algorithm. You know, my favorite algorithm is, I will say that the combination of many, but I'm going very first, if I know, if my brain recognize this lesion from the first sight, I'm feeling well. If I cannot recognize this, this is already idea for the biopsy or to understand what is going on. Of course, if I cannot recognize, it could be malignant and it could be irritated lesion. This is also a very tricky thing to differentiate between them. And then, of course, I'm looking for the whole body, and I like to take a look what neighbors are doing, how they looks like, and yeah, this is my way. Of course, ABCD calculation of ABCD, not for every lesion, only for some lesions.
Okay, maybe this is the last question.
Yeah, maybe we can take a look to these cases. Yeah. So, okay, case number one, and this is just in the topic of this pigmented, flat pigmented lesions on the face. 62 years old female, superficial basal cell or lichenoid actinic keratosis. So in this case, if the question is only regarding two possibilities, my favorite will be lichenoid actinic keratosis, because for basal cell carcinoma, it doesn't look like basal cell carcinoma. I expect to see other criteria for this lesion. Of course, in this case, we can differentiate from lichenoid actinic keratosis. We can differentiate from LPLK. Maybe it could be also differentiation with a lentigo malignant. Yeah, of course, it's necessary to take a look for whole face, but in this case, more preferable for lichenoid actinic keratosis. The second one is the pigmented lesion on the plantar aspect of the second toe of the 40-year-old female with a family history of melanoma. She has more than 100 nevi. She's not sure how long this lesion have been there. So, and in this case, 100 nevi, it's not a problem. And 100 nevi on the body and one more nevi on the acral area, not problematic. But I think in this case, this is a really very good clue to the benign lesion, and we see how this pigment is located here. Of course, maybe I would like to see more sharply this area, but I think this is just a nevus, and yeah, even acral nevi could appear during the lifetime. So next, 70 years old female. It's also very good case in context of question how to differentiate. So is this irritated or malignant? So of course, if I see this, I see that this is a sun exposed area. This is a sun damaged skin around, and two diagnoses will be at first sight. This could be Bowen disease, or this could be maybe also squamous cell carcinoma, but more probably it could be also irritated septae. In this case, here we can see this whitish halo around the vessels, like here, but I'm not seeing that this is a loop vessels. There is a big red clots. Yeah, that's why I will say that yeah, biopsy will be more helpful. We see also some keratin here. If it will be squamous cell carcinoma, it will be high differentiate squamous cell carcinoma. Anyway, I will prefer to make biopsy in this case. So, and next case, 6 years old, male, asymptomatic, slight growth with age. Well, I see chrysalids. Do you? So, and of course, the management of the Spitz nevi is very, very interesting. In this case, as this lesion is not symmetrical, I will better prefer to excise it. But today we are not talking about the management of the Spitz, but I see chrysalids or not. So my answer is, in this case, if you have your dermatoscope, and I hope that all participants have Dermlite dermatoscopes, and all of them are equipped with the possibility to use polarized light. When we switch from polarized to non-polarized, we will see this blink effect when we switch on polarization. And in this case, we will see much better the structures which could be chrysalis. And one more tip to taking home, I will show you a small video, because we can apply these our dermatoscopes not only on the lesion and switching from polarized to non-polarized, but we also can turn to the right and to the left and take a look to this small video. Follow these lines here and here, yeah, and what happens with them. We are turning to the right, and some of these lines are growing, some of these lines start to disappear, and when we turn back, these lines appear and disappear. Yeah, from my point of view, this is a really very, very good thing. How can we say, is this chrysalid structures or not? Yeah, take a look. They are growing, they appear and immediately disappear. So, some more questions?
We have another one. We should wrap it up. Maybe this is one of the last or the last one.
Okay.
You could recommend for an absolute beginner as an entry to dermoscopy.
First of all, I will recommend to find a good mentor. I think this is a key for your success. Of course, next will be dermatoscope, next will be good atlas of dermoscopy. Well, I can recommend there are very nice sources like a web page of International Dermoscopy Society. You can become a member of IDS without any payments. It's free of charge. You can find a lot of very good podcasts on this website. Please use Dermoscopedia. Dermoscopedia is also very interesting, and you can find a lot of good things. But for the very, very beginners, my recommendation is try to find good mentor.
Okay, thanks, Raimons.
Thank you very much.
This wraps up our second episode of On the Spot, and I think we would all be excited to have all of you back for our next episode, which should be in about 2 weeks. We will try to adjust the timing a little bit because we have people from all over the world. We have people from over 60 countries here. So it's very difficult to schedule a time that works for everyone. But we'll try to adjust a little bit to make it work better, maybe for our participants in Asia Pacific, where it's very late. And I appreciate everyone who is still awake at this hour. Great to have you. Hope it was worth your time. And after you leave, you'll have a chance to leave some quick feedback that would help us a lot to adjust for future episodes. And for Raimons and the entire 3Gen team, I thank you for taking time to be with us tonight or today or this morning. And depending on where you are, have a great evening, an enjoyable morning, a wonderful rest of your day, and a great weekend. Use those superpowers and stay healthy. Thank you again.
Stay healthy.